Hello, my name is Brittany Rivers. This is from a presentation that I did a few months ago on the BMI and gender affirming care at a local trans health conference. I decided that it might be helpful to put out a recording in case anyone else would like to learn more about this information. So I want to start out with that I'm a therapist, I'm not a physician, so I cannot give medical advice or medical recommendations. However, I wanted to look at this topic with centering mental health impacts and thinking more about the complexity of this topic and how it is playing out in the trans community. I have worked with clients and seen things come up in the community about people really struggling to find access to care because of their BMIs. And so I wanted to talk a little bit more about this topic. My motivation is liberation for all. And when I did this presentation, I did take a moment, and I'll take a moment here now to acknowledge our fellow healthcare providers in Palestine who are fighting for their lives and fighting for the lives of their communities. So there's many people, including myself in the trans community, that acknowledge that there are some overlaps between what is playing out in Palestine and what the trans community is fighting or facing in the United States in terms of the dehumanization and justification for violence. And although not to equate these two areas, to acknowledge that they are coming from the same root causes. And as Fannie Lou Hamer said, nobody's free until everybody's free. That these are fights for liberation around the world are interconnected and all tied up together. And I hope that as we go through this presentation, I just want to open that door or that window to maybe think about how are there similarities here in terms of how we're looking at one community versus another, who's human, who isn't, who deserves safety, who doesn't, who deserves access to medical care, who doesn't. Uh, these are conversations that are happening globally about the trans community and Palestinians. So I am open to collaboration. I'm not open to debating the humanity, dignity, and needs of fat people. So this word, fat, so I may have already activated you. Uh, and that's what we're talking about today. We're talking about communities that are dehumanized, and people have a lot of feelings about them. So, how does that? I want to take a moment to encourage you to take a pause and see how that word lands. Fat. Are there certain feelings or thoughts, body sensations that come up when you feel into that word? Different experiences, different people in your life, messages that you've received about fat people. So I use this word as a member of the fat community, a member of the fat liberation community, and it is just a descriptor. We put a lot of connotation, we put a lot of value, judgment on it, a lot of moral assessment, a lot of assumption, bias, and judgment. It is just a description. And unfortunately, it has such a big response from people that literally they will risk their lives to get away from it. Other people will encourage them to risk their lives and shame them and judge them, discriminate against them, all to get rid of that. So it's important, I think, as providers to think about, a lot of us think, oh, well, I'm objective. so I don't need to worry about these things when unfortunately you do, because just because you're trained as a provider doesn't mean that you haven't been socialized in our society, that you don't have internalized biases. And if you're not regularly examining those biases, it's likely that they are playing out in the way that you offer healthcare and you offer services. And the assumptions you make, the assessments you make, the recommendations you make, how you treat one patient versus another, it's likely that it will be playing out and is potentially causing harm. Unfortunately, these biases are built into our medical system, in our institutions, in our training, in our academic and research institutions. These biases are all present. So it's likely that you've picked some up along the way. And so today is an opportunity to look more closely at the biases that you may be carrying, or may just be something that's embedded in assumptions about healthcare that you may not even realize. Another thing that I wanted to note is that I'm interested in being part of multidisciplinary coalitions working against weight stigma. If that's something that you're interested in, feel free to reach out. So, as I already have, maybe brought up some things that you might have found activating or your nervous system might have responded to. I'm going to continue to do that throughout this presentation. So I'd encourage you to do whatever you need to do to take care of yourself with that. These are some agreements that I wanted to write up just to note, just to give more, even more explicitly where I'm coming from. And so because I did this presentation with people that are valuing and offering trans affirming healthcare, was hopeful that we were in alignment with these things, and that if you are watching this, if you're not in alignment with these things, then it's unlikely that this is a good presentation for you. But that this is the place where I'm coming from in offering this talk. And so when you might feel that you're activated, this might be something to reference back. If you're having some resistance or reaction to me or what I'm saying, is to go back to this as a reference, that this is where I'm coming from and telling you this information. That that hopefully we care about trans people. About that. To acknowledge that the trans community is targeted in our society, and that is even more so an issue with the the new administration that will be coming on, uh, which is a whole nother topic we get into, that access to care is a priority, as care is life-saving. Denying access to care can lead to people experiencing suicidal ideation and attempts. So literally, this is life-saving care. And so when we say that we care about trans people, one of the questions that sort of in a way might be brought up here is, do we mean all trans people? And what do we mean by care? And is that actually effective? Is that harmful? Are there some issues with it? So that's a little bit of what we'll be grappling with in this presentation. So the BMI is a barrier. The BMI is a measure, a health measure that is widely used. It is the body mass index, and it is a comparison of someone's height to weight, and it pops out a number that says that you are underweight, average, normal weight, or overweight. It's a girlfriend, or obese. And they even have a spectrum of obesity. So, based on the BMI, different providers will give different healthcare recommendations potentially. So, the WPATH that comes up with the guidelines, who establishes the guidelines for gender affirming care, does not have guidelines on BMI in terms of gender affirming care procedures. However, providers, clinics, and insurance companies can set cutoffs and require weight loss prior to care. So, in these instances, these entities are saying that in order to access this procedure, you must be a certain BMI or lower. And if you're over that BMI, then you are not given access to that procedure. And some clinics are requiring weight loss. They're requiring that someone sustain weight loss for a certain period of time. And so this can present a real barrier for some individuals, and particularly because in the transgender and gender nonconforming communities, um, people often carry a higher BMI than the general population. And there's a few different reasons that are listed in the research for this. One is hormone treatments. As you may know, for many people, as part of their gender affirming care, they engage in hormonal treatments, and that can contribute to weight fluctuations. There is higher risks of disordered eating in this community. So, another bias that will challenge is the assumption that you can look at someone and tell if they have an eating disorder. The reality is that, or sort of the assumption that if you have an eating disorder, you are automatically going to be underweight, when the reality is that people of any weight or any BMI can be struggling with an eating disorder or disordered eating. And this presents a real challenge in the eating disorder treatment community, as there are some people that are really struggling in need of higher levels of care and are not granted access through their insurance companies to cover treatment because of their BMI. So, again, there can also be certain eating disorder or disordered eating behaviors that can contribute to weight gain, or having a history of disordered eating can also, for some people, lead to weight fluctuations as well. So, the other issue that was brought up is a lack of access to health promoting resources. Another assumption here, assuming that if someone does have access to health promoting resources or is engaging in them, that they will automatically be of a certain BMI, which is not the case either. People can have access and be engaging in health promoting behaviors and be healthy at different BMIs. So, however, it is noting that this community is often, members of this community are often under resourced and often don't have the resources they need to tend to their health in the ways that other communities have access to, which is part of the discrimination that the community is facing. Now, when we look at people of color, so the BMI was made up based on correlation, well, excuse me, made up based on population data. Often in the research, it's correlational population data. So I'm just used to saying that phrase. But it was made up based on population data of white men in a European country, and then was applied to everybody else. So when we're looking at, even if we're saying that we believe that the BMI is a good indicator of health, if we look at Black women, for example, again, research is often talking in binary terms. So we'll hear, if we're looking at Black women, for example, even at higher BMIs where we would see certain, maybe an increase in certain health conditions, that's not the case with Black women. And so in different races and ethnicities, there can be a different average BMI, a different norm. So here's one level of discrimination that the BMI is used when it's a measure that is not normed to a particular population and then is being applied to them as a determinant of health in healthcare settings. And then on top of it, you are going to deny people access to care based on a measure that does not even adequately apply to them. So here we're talking about community members that are carrying multiple levels of marginalization. They're living at, as in the work, coming from the work of Dr. Kimberly Crenshaw, intersectionality. They're living at the intersection of multiple marginalized identities and then seeing an even greater barrier to accessing care because of the utilization of the BMI as a determinant of whether or not someone can access this care. So, a little research. I do want to acknowledge that there different research studies say different things. These are some of the studies that were highlighted that showed that in these common procedures that are part of gender affirming care, that there wasn't really a significant difference in outcomes for patients of different BMIs or over the common BMI threshold that is set. And I want to acknowledge that and I hope that if people are really going so far as denying, or clinics or providers going so far as to deny people access to this care, that they really do have good research to support doing that, especially when we're looking at such a vulnerable population. However, one of the things that was brought up is that if we just make this sort of assessment that, hey, if you're over this BMI, you can't get these procedures, there's a whole lot of data that we're missing out on to actually prove, does this really cause these significant complications? Are they significant enough for us to deny access? Are there alternatives or opportunities for research and development and building new techniques and strategies to reduce complications so people of any BMI can access this care? So it is a consideration here, or something that we should be considering. I also wanted to bring in this concept, the connection between anti-fatness and racism, or anti-fatness and anti-blackness. These are two excellent resources for learning more about these connections. Fearing the Black Body, Dr. Strings goes into, as it says, the racial origins of fat phobia. When did fat first start to become an issue for us in our society? When did we say, okay, this is bad, we need to get away from it? And she actually connects it to the growth of white supremacy in defining what is a white body versus a Black body. How do we justify white supremacy and white superiority? Well, a white body looks the certain type of way and a Black body looks the certain type of way. So fat became, fat and different shapes and sizes became more associated with Black bodies and utilized to justify violence, oppression, discrimination, and enslavement of Black bodies. And different things that were associated with white bodies, again, being a certain size and looking a certain type of way, was associated with being more rational, intelligent, morally superior, um, closer to God, those kind of things, and to justify the violence and dehumanization of Black people and uh, people of the global majority. One of the things that stood out to me is some of the ways that Europeans hundreds of years ago going into Africa would talk about the people, the community, and their bodies, and that they are, lazy, they just sit around eating all day, unintelligent. And these are some, I thought it was interesting because if we did a poll of what are the common negative stereotypes people have about Black people, about fat people, is very similar things. So this is an opportunity to sort of think about, where did these biases come from? What are they based on? How do they play out in how we look at our patients and how we think about ourselves and our own relationships with our bodies? Um, the Belly of the Beast is, it's just it's a very good book to challenge. I found it to be a challenge to different things that I might be thinking or that we might think as a society. And one of the things that was brought up in there is this concept of health and wellness, and sort of like what type of health or wellness is possible when you are living in a body that so much violence is directed towards, where people literally want to kill you, they want to oppress you, they want to discriminate against you, they want to be violent against you. Like like what health is possible in that type of society? And I just wanted to note, for me, sort of the absurdity is that we're working with patients or clients that are living again at the intersections of multiple levels of marginalization or exploitation in our society, significant violence directed towards them. Somehow they find their way, and I know not everyone's experience is this way, but in general terms, like, they find their way into your office, and then you're like, oh wait, on top of it, on top of all of those things in that context that you're having to deal with, you need to lose weight. And the only way you're going to get what you want is if you lose weight and your body conforms to these expectations that we have. So I think that it's really questionable there, and also how much harm we as providers and the medical systems that we're in, how much harm we participate in when we decontextualize our clients, our patients, when we take them out of the context that their bodies and nervous systems and minds and brains are having to navigate, and what sort of assessments and assumptions and recommendations we're making about health, and how that can be quite harmful and violent, and participating in that violence that these communities are facing. So, weight bias in the medical field. So, these are some studies that were pointed out, or some things that were coming from different studies, that weight discrimination is actually on the rise in the US. Um, Over a third of medical students have a strong anti fat bias. It's pretty significant. Over 50% of primary care physicians viewed obese patients as awkward, unattractive, ugly, and non-compliant. So I did want to note that I put that star there with obese, just to acknowledge that for some people, this is considered a derogatory term. It is used in a way to discriminate and deny people access to care, to judge them, to make assumptions about them, and is so unhelpful that sometimes it actually is leading to long-term impairment, development of significant long-term health impacts, like development of different health conditions or loss of organs or capacities, or even death, because of how the stereotypes and judgments play out with this. So they're like, where are you going with that? Well, take, for example, if someone is going in, if a patient is coming in and they're complaining of different symptoms and issues, and they're being told by their provider, no, 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 you don't, you just need to lose weight. That's all this is. And they don't do further assessment. Well, some patients are avoiding healthcare because they know that they will just be shamed. And then some patients, okay, are told this, and then their health conditions go untreated, and that can again lead to long-term impairment. It can lead to um, even death in some cases, where people's symptoms are being brushed off as like, oh, it's just your weight, it's just your weight. And what's actually going on is missed or not dealt with. And this can also go the other way, with the assumption that people of certain body weights are automatically healthy, when that's not necessarily the case. So these physicians were largely viewing this as a behavioral problem and share broader society's negative stereotypes. And so again, thinking about, how this plays out in terms of patient outcomes. So other healthcare professionals, excuse me, like people who actually study this topic, who actually study obesity associated stereotypes of lazy, stupid, and worthless with obese people. So even a group that understands the complexity of obesity and how it is contributed to or caused by genetic and environmental factors, not simply a behavioral issue. So there's already some things that we've talked about that can contribute to weight fluctuations, but there's other things like if people have certain health conditions, if they're taking certain medications. So there's a lot of factors that can play into what someone's weight is. And it is really um, unhelpful to try to simplify it to just being a behavioral issue. And you can see maybe potentially how then that can lead to providers having negative assumptions about patients when they're saying, oh, you need to lose weight and you need to do X, Y, and Z. And maybe the person says, hey, I've tried all those things. Well, then you get into if you have this such a strong bias and are not in touch with the reality of the complexity of these situations and the research, then you may say, oh, well, you're just lying about it. So again, you can get into some pretty negative views of patients when you hold these biases. Studies have shown of nurses feeling repulsed by, uncomfortable caring for, and preferring not to care for fat patients. So, one of the things that came up for me is thinking, okay, well, what kind of healthcare are these patients receiving? And how does that play out in terms of outcomes? And, even if we were looking at this concept of complications from procedures, and I think this is where we get into that complexity of when you say you're offering gender affirming care, when you say you respect the dignity of trans people, which trans people are you talking about? Are you talking about the people, like all trans people? Because that also includes people that live at this intersection. And, you know, what kind of treatment are they getting and when they're in the before, during, and after the procedure? If some providers are having these kind of negative feelings about their patients. So some of the downsides of centering weight. So one of the things that I want to look more into, but just wanted to throw it out there that came up in some of the research is that how these weight-centered public policies can contribute to potential human rights violations. I'm looking to get more into that research, but just wanted to throw that out there of how big this stuff can get when we're talking about it in terms of discrimination. So, centering weight can increase bias, decrease quality of weight, increase body dissatisfaction. So, when we're speaking about a community that already may be struggling with gender dysphoria and some associated body dissatisfaction and disassociation, and then to encourage treatment that is focused on weight, I think is very problematic in terms of someone's mental health. And these are some of the other things that were listed. We've already talked a little bit about some of them. So, some of the risks of intentional weight loss. So, one of the things that was pointed out is there's actually minimal evidence supporting sustained weight loss. Most people that are trying different interventions are gaining the weight, often gaining the weight back more, often gaining the weight back and more. And so you might say, oh, well, I read this or that study. And one of the things that's pointed out in the critique of the research is that often these studies are looking at very short periods of time, like usually 1 year or less, often less than a year. And so when you're seeing the weight gain come back, what I've heard is like we're looking at more of the 2 to 5 year mark where you see the weight come back. So it is questionable of even holding that as a recommendation. And so it's sort of putting patients in this difficult situation where it's assumed that this is attainable and achievable based on bias. And so they're given these recommendations and then, sort of judged when it doesn't work out, instead of the medical field, which is something we'll talk about later, coming up with alternative solutions to these issues, which is, again, what we'll talk about in a moment. So, another risk of intentional weight loss is weight cyclings. This is similar in a way to yo-yo dieting, where people's weights are going up and down, and that actually is pretty hard on the body. So these are some things that have been associated with weight cycling. So again, somebody has a history of dieting, they have a history of disordered eating. It's really hard on our bodies to do that. And so this is one of the critiques of these BMI studies that are associating different health conditions with BMI, is that often this is something that is not assessed, whether somebody has a history of weight cycling and how that could actually be an independent variable that's contributing to the health outcomes that we're seeing. As we talked about with this level of discrimination, most people or many people have tried to change their body weight in the past, maybe have tried many times. And so that could actually be the thing that's contributing to these health conditions that we're seeing. A couple other things that have been pointed out in research as other variables that are actually causing these health conditions. One is experiences of weight stigma. So that discrimination that people are experiencing in their lives, as it's noted, that weight discrimination is on the rise. Even medical providers who have different information showing up in their research are still holding these biases. So that is really hard on our health. And then the other thing that was pointed out recently was social isolation. So again, potentially connected with the experience of discrimination and the internalized shame that goes along with it, is that people might be experiencing social isolation, and that is really hard on our bodies as well. So again, just to bring a little bit more complexity to this, that there could be other variables that are actually the cause of these health associations that we're making. Another thing to sort of think about here is the disordered eating risk. So, as we've already talked about, the transgender and gender nonconforming communities already have an increased risk of disordered eating and other mental health conditions. So it is potentially dangerous to be encouraging this focus on intentional weight loss. And this is something that people in the community have brought up and pushing back against this focus and the BMI cutoffs, and had to fight back against this for their own health, because focusing on weight loss they know would be harmful to them. So the other risk with this is the mortality risk. So for many people, not everybody, but the focus on intentional weight loss can lead to disordered eating and the development of eating disorders. Eating disorders are one of the most, if not the most, lethal mental health conditions. So it is very serious to point someone in this direction. And again, I don't think that a lot of people are thinking about this. They're just thinking, oh, weight loss is better. Like you want to be a lower weight, that's better for your health. And they're not considering these potential issues that could come up. So the other thing that we are potentially risking here is impacts on wound healing. So if someone is undernourished and they don't have their body doesn't have the resources and the capacity that it needs to really heal and recover from surgery, that we might be, again, putting them at more risk for complications from one of these procedures if they, again, don't have they're not nourished to really go through this process. So, a couple of treatment options here. So treatment option one is coercion, shame, and weight loss being the only option. So I didn't come up with this term. It was brought up in the research that It's pretty coercive. We have a vulnerable population that is experiencing discrimination. They are experiencing prejudice. And then we're saying, okay, if you want, if you want this thing, if you want this procedure, you got to do this other thing first. They're coming in, they're wanting one procedure, and we're like, no, you have to do this other thing first that they did not ask for. Now, some people may want that. They may want to have a weight loss treatment. But for people that don't want that, or people that are saying like that would be harmful for them based on their medical complexity, based on their history, that it is pretty coercive to say, you cannot get this thing that, again, is a life-saving procedure unless you do this other thing first. And that is coercive. So, one thing I wanted to point out with this, and I talked about this a little bit before, is that, again, we have this vulnerable population. And rather than those with power, the providers, institutions, the clinics saying, okay, we got to figure out how to address this problem. Instead of saying that, they put it back on the patient and say, no, 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 you need to change and conform and fit the standard, fit in this box in order for us to give you this care that you may save your life, that you're maybe desperate for. And so I just want to point out that I believe that is the system putting that burden of their own incompetence and their own bias on patients that are already caring so much in our society. So option two would be beyond weight loss, thinking more about what's accessible, thinking about bodily autonomy and choice, where bodies of all sizes are treated with dignity and respect. And we have a healthcare system that has the capacity to care for all before, during, and after procedures. So, again, this context, we have a very vulnerable population, commonly denied human rights, experiencing stigma and prejudice, limitations on freedoms being eroded as we speak, discrimination and violence. And as a result of that discrimination, which we could call minority stress, higher rates of depression, anxiety, suicidality, complex PTSD, disordered eating, we've already talked about, and a medical system that often lacks training and experience in working with them. Experience of discrimination that often lead to avoidance of healthcare. So just thinking about that in that context where someone may be experiencing these things, and as a result, maybe typically they usually avoid even seeking healthcare. So they're wading through all of this to get to make that phone call to a clinic, to a provider, to be told, no, or you have to change, or I won't even see you. So, moving forward, we can ask ourselves, should the risk of complications mean a denial of access to care? I mean, when I'm looking at this complications term, like when we're holding it in this context, these complications better be pretty severe if we're going to say, like, you just can't get this. With a vulnerable population, that again, this is life-saving care for them. Should that really mean a denial? And that we have an opportunity to really engage in informed consent and shared decision making. That was my dog. He keeps running back and forth. If you hear a little jingle. Um, so we have an opportunity to really, or I think there is an opportunity to really work with patients and weigh out the options, weigh out the risks, see if there's a way to come up with a plan together. And then also systemic changes. So, unfortunately, often surgical statistics disincentivize working with higher weight patients. Can we come up? And that's what's so tricky for me is like, I'm not a surgeon. And unfortunately, I've heard more mental health providers than surgeons actually talking about these issues. Maybe I'm not in those spaces. If you have those resources, please share. But to come up with another avenue. But again, if we have that bias that fat is bad, that fat is the worst thing, and that is embedded in our training, our education, and our systems that we're working in, maybe we're not even thinking about that. So I want to hold that compassion for providers navigating this stuff, as they may not even have thought about this. But that why aren't more people saying, like, why are we allowing a standard where so many people are being told they have to lose weight before they undergo surgeries? But they're also being told, 'cause this is something that's often brought up, is like, okay, so you're saying I can handle weight loss surgery where they're literally cutting up some of my organs, but I can't do this other surgery. I can't handle that. So it's some questionable things, and maybe there's more to that story, but um, again, that might be putting people at more risk in going into procedures in some ways, with that focus on weight loss and those impacts and that distress on the body. But is there an opportunity to create other avenues um, for research and development for improving surgical care and recoveries? And also to develop the skills to properly care for fat bodies. Can we invest in that research? And this is sort of a microcosm of what's going on more broadly, because there are many instances and different types of procedures where people are being told they have to lose weight before they can get access to care. And it's causing pretty significant impacts for some people that are trying to get needed health care. So here's some of my references if you want to review them. Might also put a couple more references in the posting. But thank you for joining me today. I hope this information was helpful, and I hope that we can work towards creating a healthcare system that honors all bodies and supports bodily autonomy, choice, and prioritizes accessibility with care, and creating more and more affirming care for people. Thank you for joining me.